Welcome back to part 76 of our Explainer series right here on Decode Healthcare with Harshal. Today, we're jumping straight into Chapter 9, Part 2, tackling the absolute beast that is acute myocardial infarction coding. If you've ever stared at a chart, totally stumped by the 28-day window, or how on earth you're supposed to sequence demand ischemia, you are in the exact right place. Let's decode Section IC9E of the official CMS guidelines. To conquer these strict CMS regulations, we've got three main targets today: the 28-day clock, Type 1 versus Type 2 MIs, and the tricky STEMI and NSTEMI evolution rules. Let's get right into it. So here's a question for you. When exactly does an acute MI officially become an old MI? It sounds like a pretty basic clinical question, right? But in the ICD-10-CM universe, hitting that exact deadline literally flips your entire coding logic upside down. It dictates your category, your sequencing, and how that whole episode of care gets paid. Section 1. The 28-day clock and timeframes in AMI coding. Okay, picture a strict countdown clock ticking from the exact date of onset. For those first 4 weeks, or exactly 28 days, you're locked into category I-21 for an initial AMI. But the absolute second you hit day 29, that acute window slams shut. From that point on, it is officially classified as an old or healed MI. But what if disaster strikes again, and the patient suffers a totally new infarction while that 28-day clock is still ticking? Enter category I-22. This is your subsequent AMI category. It is specifically built for a brand new heart attack that crashes right into that original 4-week time frame. Now, you can't just code this new MI and pretend the first one didn't happen. CMS demands mandatory sequencing here. Your new I-22 subsequent code takes the lead in slot number 1, and you absolutely must back it up with the initial I-21 code right there in slot 2. You're basically forcing the claim to tell the complete chronological story. So what happens when the dust finally settles? After that 28-day window closes, if the patient is no longer receiving active care for the MI, the guidelines explicitly tell us to assign code I-25.2 for an old myocardial infarction. The acute phase is officially done, the I-21 code is retired, and we transition over to the history code. Moving on to Section 2, Type 1 versus Type 2 MIs and classifying the infarction. You absolutely have to know the difference between a Type 1 and a Type 2 MI. A Type 1 is your classic heart attack. Think physical blockages like plaque rupture or thrombosis. But a Type 2? Completely different beast. This is all about demand ischemia. It's a supply and demand oxygen mismatch, usually triggered by something severe like massive blood loss, anemia, shock, or extreme hypotension. Because a Type 2 MI is essentially a secondary effect, your sequencing has to reflect that clinical reality. For a Type 2, you must always, and I mean always, sequence the underlying condition driving that oxygen starvation first. So if severe anemia caused the Type 2 MI, the anemia code takes slot number 1, followed immediately by I-21.A1 in slot 2. Now, listen up, because this is a massive coding trap. When a provider writes demand ischemia, do not even think about assigning code I-24.89 for other forms of acute ischemic heart disease. The guidelines are crystal clear here. You code demand ischemia directly as a Type 2 MI using I-21.A1. No exceptions. Let's connect this back to our 28-day clock. This is crucial. You can only use that category I-22 subsequent code if both the initial and the new infarctions are Type 1 or unspecified. If you have a Type 1 MI and 2 weeks later the patient suffers a Type 2 MI due to shock, no I-22 for you. You code the shock, then I-21.A1. Category I-22 is strictly for Type 1, compounding on another Type 1. All right, Section 3, STEMI and NSTEMI evolution and the conversion traps. Just to level set clinically, a STEMI, ST elevation myocardial infarction, means a totally blocked coronary artery. It is the most critical, severe type of AMI. And because it's so severe, ICD-10-CM guidelines practically bend over backward to ensure you capture that severity on the final claim. Here's how that plays out during a hospital stay. If a patient comes in with an NSTEMI, but it worsens and evolves into a STEMI during their care, you code the STEMI. The worst-case scenario wins. But wait, what if they present with a massive STEMI, and brilliant thrombolytic therapy actually improves it to an NSTEMI on the EKG? You still code the STEMI. The golden rule is, once a STEMI, always a STEMI for that episode of care. Of course, we all know clinical documentation in the real world is rarely perfect. CMS gives us strict defaults for this. If the chart just says AMI, use I-21.9. Documented as a type 1 STEMI, but the doctor didn't specify which wall of the heart, assign I-21.3 for unspecified site. And if it's a non-transmural MI but a site is documented, you still default to the subendocardial AMI guidelines. Simple as that. Oh, and one highly specific rule you cannot afford to miss involves the number 24. If your facility admits a transfer patient who received TPA therapy at an outside facility within the last 24 hours, you are required to slap code Z92.82 onto that record as a secondary diagnosis. It's a vital piece of the puzzle that explains their clinical timeline. All right, let's lock in the key takeaways from today's explainer. Number 1, respect the 28-day clock to perfectly differentiate your initial, subsequent, and old MIs. Number 2, for type 2 demand ischemia MIs, the underlying cause always takes the principal slot. And number 3, never ever downgrade a STEMI on your claim. It always overrides any NSTEMI conversions. If you found this explainer helpful, go ahead and smash that like button and subscribe to Decode Healthcare with Harshal so you never miss a beat. We've completely mastered the incredibly strict rules of the heart today. But what happens to your claims when that exact same ischemia strikes the brain? It's a totally different minefield. Join me in part 77 as we decode the complex world of CVAs, TIAs, and stroke sequelae. Keep decoding, and I'll see you next time.